Really excited to welcome everybody to our inaugural event of PINE, the Pulmonary Infection Network of Expert Conference. This is an initiative of the Early Career Working Group of the Pulmonary Infection and Tuberculosis Assembly of the American Thoracic Society. And I'm very pleased to co-chair the Early Career Working Group and to present this conference today. And I'll tell you about our new conference format. I'll introduce our speakers, and then I'll pass it off to our presenter and our discussants. So to orient everybody, this is a new initiative. So PINE, as we're calling it, is going to feature a new pulmonary infection each month. So our inaugural conference right now in February of 2021 is going to be on non-tuberculous mycobacterial infections. And then next month in March, to coincide with World Tuberculosis Day at the end of March, our event will focus on tuberculosis, and we will feature subsequent infections in different months. The format of the conference is that we're going to have a more junior member of the assembly or of the community present a case, and then there will be some poll questions along the way to poll the audience, your opinions on this case, what you would have done, your understanding of your practice. And we have some guest discussants who are experts in these infections who will provide us their thoughts on how this case could be best managed or where our gaps are in understanding. This case format is modeled off of our non-tuberculous mycobacterial clinical case conference, which is a separate conference that Elizabeth Talbot, who's at Dartmouth, and I co-founded. And if you're interested in attending more events on NTM, just send us an email. We'll add you to that list. So to kick it off for this conference, so today I'm very delighted to have our first presenter, Dr. John McGinnis. Dr. McGinnis did his medical school at the Rutgers Robert Wood Johnson School of Medicine, and then he did internal medicine residency and a chief residency at Yale New Haven Hospital. Then he went on to do a fellowship in pulmonary and critical care medicine at the Perelman School of Medicine at the University of Pennsylvania, and he is now on faculty at the University of Pennsylvania as a clinical instructor of medicine in their pulmonary division. I'm also delighted to have two discussants today. We're very pleased to have two world experts. So we have Dr. Rachel Thompson, who's a thoracic physician and a clinical researcher at the University of Queensland. And we also have Dr. Chuck Daly, who's a professor of medicine at National Jewish Health, University of Colorado, and the Icahn School of Medicine at Mount Sinai. And I should say, Rachel, in addition to being, both of our speakers are experts on NTM and mycobacterial infections, and Rachel is also our current chair of the Pulmonary Infections and Tuberculosis Committee for Assembly for ATS. So I'm going to pass it off to John to begin our case.
Great. Well, thanks for the kind introduction, and I do want to thank Kira and Elizabeth for setting up the NTM case conference, which has been fantastic, and I think this is work we're kind of building off of that, so hopefully this will do that justice. So without further ado, we'll get started. I don't have any disclosures here. I just think a bit, I'm junior faculty, just finishing fellowship, and how I first encountered NTM was, through board questions and maybe a couple cases in residency where it was very straightforward. You had a clear, a Lady Windemere's type syndrome, a right middle lobe infiltrate. You follow ATS guidelines to make a diagnosis. You start treatment, and you're done. It's beautiful. It's simple. And I think my purpose today is to present a case that there's many more twists and turns, and kind of the more real world is something more analogous to thinking about Odysseus's Odyssey through a narrow strait between Scylla and Charybdis. This is a story from the Odyssey where basically, Odysseus has to make a decision whether he kind of veers close to the cliffs and to a six-headed monster, or he kind of takes his chances through a whirlpool on the other side of the strait. And how do you decide? So which decisions do you make in terms of kind of difficult clinical decisions, while treating and following up an NTM case? So with that said, my goals today are to use a case to apply a critical lens to thinking about how to monitor people with NTM lung disease, and once you start them on treatment, how they're doing on treatment. Understanding the complex relationship between the environment and host and how that influences the clinical course, and develop a framework for some of these difficult clinical decisions where there isn't clear guidelines or evidence to kind of guide treatment, how to use kind of principles to make some of these decisions. So with that, the case I'll introduce is a 65-year-old gentleman who's generally healthy, just some chronic musculoskeletal pain. And about 2 years prior, he developed a cough, and kind of a purulent cough, had imaging that looked consistent. He had like nodular bronchiectatic findings on imaging. And then he eventually was diagnosed on sputum with kind of a high titer of a MAC pulmonary infection. And then he was started on kind of standard first-line therapy with azithromycin, rifampin, and ethambutol. And he completed about a year of therapy. He had some intolerances early on. They had to interrupt for brief periods of time, and eventually they dose reduced to rifampin, but he did complete close to a year of therapy with three medications. And he felt great. He, after a month or two of tolerating therapy, he was asymptomatic. He was active. I think, but the one kind of hiccup in kind of when I first met him, there really wasn't a documentation of that. He clinically got much better, but unclear if he ever cleared cultures, which will be kind of one of the first points we'll discuss. And so seeing him initially, he had this, again, sort of 6 months after doing this, chronic productive cough, still fairly active, but kind of bothersome every day, productive of sputum, and otherwise had a fairly unremarkable past history. So with that, we'll jump right into our first poll question. So in your clinical practice, how often do you monitor sputum cultures after starting treatment? We'll start there.
So this is, you guys should have seen a pop-up on your screen with a poll question for Zoom. It's a single choice answer, so write it in, select one, and if you want to choose an option that's not there, feel free to use the chat at the bottom and type in your answer to us. And then we'll have our discussants weigh in after we've given people a couple seconds to complete their votes.
I'm going to end the poll now.
Great. So it looks like we'll ask our discussants to weigh in. So it looks like a 53% of patients, 53% of participants said that they check sputum cultures every 2 to 3 months. And this is probably a practical real world answer as opposed to what one would expect. What do you guys do, Drs. Daly and Thompson? What do you do in terms of what your guidelines are and what your clinical practice reality is?
Well, Chuck's still muted, so I'll start.
Yeah, go ahead.
Yeah, look, this is a real challenge in clinical practice, and it's a very common problem when you get second opinions or referrals for failure is a lack of sputum cultures documenting where things are going. And you commonly see patients who've been on treatment for a year and you've got no idea where they're at. In the ideal world, monthly sputum cultures are great because, as you know, the goal of treatment is to get patients through 12 months of negative cultures. And the sooner you document that first negative, the shorter the duration of treatment. So in an ideal world, I would aim for monthly sputum cultures and get them started as soon as possible. But in reality, that's not always the case. And for many of these patients, it gets hard to collect sputum samples, particularly after you start treatment. And so you often end up with getting some every 2 to 3 months. But I think if you aim for every 3 months, you probably only get them every 6 months. So I always aim high and ask the patients to submit as much as possible going forward, because for them, it means the sooner you find out, the sooner you get them off the drugs.
Yeah, there are 2 reasons to get the sputum cultures. One is, we just heard, is duration. The other is, this is how we define treatment refractory disease. because that's going to be their result of their culture status at 6 months. And if you don't have multiple, you're not very confident that that person is positive or negative. So the more cultures you can get in that first 6 months, I think the more helpful it will be for you to define refractory and just to see in general how the patient is doing. Duration is very important. Patients would love to shave a few months off if they could. So we recommended in the guidelines every 1 to 2 months, but like Rachel said, real life often interferes with that. And I would say probably 2 to 3 is about as frequently as most of us end up getting it.
Great, thank you. Okay, back to you, John.
Great. Yeah. With that, so just to kind of recapitulate what our experts said. So sort of the expert opinion is, kind of a month. Most clinical trials in NTM was a month. And you could see sort of the guidelines by society there. A little bit of variation, but closer to the month mark. But as was mentioned, kind of real world evidence kind of shows that this really is because of multiple reasons, either improving and hard to give a sputum or just, life reasons. At any given month interval, there, wasn't, so this was about 300 patients in follow-up. So, in every interval, you're only seeing maybe a third of patients giving a culture. So you can kind of see that in the real world, this is much more what it would look like. And maybe another point of discussion is so documenting microbiologic clearance is clearly one aspect of treatment monitoring, and wanted to sort of ask the discussants too, what are some other metrics you monitor with patients? Is it just asking them how they're doing? Do you use a kind of validated tool for symptoms? And how about imaging and lung function? Those seem to have less of a clear role. So I wanted to hear what kind of our experts do here.
You want me to go this time?
Sure.
Yep.
So I think all of these are in toto what we use. Many years ago, there was a study, it was never actually published, a separate portion of it. But when you looked at treatment outcomes in a group that was prospectively treated for MAC, at the end of the day, there were very few home runs, meaning people would improve microbiologically, clinically, radiographically, but not many got better in all three domains. So I think you have to look at multiple ways to determine whether you think your patient is responding. We've already mentioned micro is very important because we have those two decisions to make about duration and treatment refractory. I think imaging, it really depends on what you see. Cavity closure is very convincing that the person is responding to therapy. Resolution of tree and bud abnormalities, I think, are convincing. Bronchiectasis obviously does not necessarily get better, and that's where we get tripped up sometimes, or we get tripped up by co-infections. But I think that determining if the patient is clinically improving, microbiologic improvement, and imaging are right now to me the most important. Rachel.
Yes, I agree, Chuck. I must say though that I've found radiology to be particularly challenging in interpretation, because more often than not we see that the disease does fluctuate, and some areas get better and then some areas get worse. And I think that it often reflects the battle that our immune system does with these organisms. And it's a little bit like putting out spot fires. When you're working on one area and clearing it up, you lose control in other areas. And sometimes radiology can be quite challenging to interpret. So I tend not to do it that frequently, and rely more on microbiology and symptoms in my interpretation.
Great, thank you guys.
Great. So back to the case a bit. So he was a never smoker, but does occasionally use marijuana. He was born, raised, and currently resides in suburban Philadelphia area. He's a businessman with frequent travel, travels to Southeastern Asia, particularly Vietnam, and when there, kind of would visit factories. His predominant job was not a factory worker, but he would kind of visit factories with wood dust and other kind of fumes, and would most of the time wear a mask, but he would clearly say that it was not always kind of adequate PPE in these environments. And then think importantly spends a lot of the year in South Florida. So he, for the winters flies down to Florida, and he has his own indoor pool and a spa. He does not do his own gardening, but clearly a lot of indoor moisture from pools and spas. His exam was essentially normal. He was a normal weight, normal appearing gentleman, not hypoxemic, and had essentially a normal lung exam. A previous workup was also looking, didn't have a lot of eosinophils. His immunoglobulins were normal, IgE normal. Doesn't have any review systems pointing towards a rheumatologic disease, and kind of the basic serologies were negative. And as was kind of stated before, he had a sort of high kind of burden of MAC in his sputum that was macrolide sensitive. And let's see, we'll see if the video actually works. Okay, hopefully people can see that, and we'll pause it along the way, but we'll let it go one more time, but kind of some apical scarring, and then more kind of scattered nodules and more concentrated kind of right middle lobe disease. Oops. We'll see if we can just pause it. Yeah, so as you can see, mostly sort of right middle lobes and nodular, and then along the way, some bronchiectatic type disease.
Is this pre-treatment, John, or is this?
This is pre-treatment. So yeah, at the time I'm seeing him, this is his scan. Oops. So my initial plan was, he had a purulent cough to start some airway clearance. He's moderately active, but kind of asked him to maintain that, if not increase some exercise, get some baseline labs. Thought about some genetic testing, but really didn't have a clear history there, and had a pretty basic or kind of unconvincing workup or symptoms kind of pointing in an underlying cause. And then getting cultures. So a bacterial culture kind of, and then fungal culture, and of course an AFB culture. So I'll come to question 2. There might be multiple reasons why he's back in the office seeing me, but I wanted to see if, so sort of choosing people to choose only one, what they think would be the most likely cause of this recurrent cough and dyspnea after completing a course of therapy.
Great, thanks. So everyone, please get your polling fingers ready.
Yep.
Enter a vote.
Popping up here. And they're likely going to do multiple different things, but what you think would be the most likely?
Okay, I'm going to close the poll now.
Great.
So let's put it to Drs. Daly and Thompson. What do you guys think? That 75% of people voted for relapse or reinfection? Is that what you would have guessed as well?
Rachel,
Yes, I think so. Yeah. I think the macrolide resistance is certainly worth checking, but if he'd been compliant with a 3-drug regimen that included ethambutol, that would be unlikely. But he only completed 12 months therapy, and for someone who was heavily smear positive at the start of that treatment, that's an insufficient, most likely an insufficient period of treatment, and this will be a relapse.
Yeah.
Yeah, also the timing, to have symptoms recur so quickly after the end of a therapy that, as you pointed out, was a little shorter than recommended. It was probably really closer to 2 drugs, since rifampin is not very active and it was dose reduced. So that probably didn't do a whole lot. But starting off with a high bacterial load and 2 drugs, I would say the risk is higher than normal when you treat MAC, but still I would think that's relapse.
There's a comment in the chat about relapse versus reinfection. It sounds like both of you guys are saying relapse, meaning that this first infection wasn't fully cured. It's not that there was a second bacterial infection that occurred.
Yeah, they recurred. Yeah. And the 2 reasons for recurrence, there are actually more than 2 reasons. We say relapse and reinfection, but there's also people who probably started off with a mixed infection, and then we're not sure. We call it reinfection when they have a different isolate at the end, but maybe they started off with that one. It just wasn't found.
Thank you, guys.
I think that's what my leading suspicion was at the time too. And again, so his sputum culture at that time, so it was a couple weeks later, the results come back, and it did find again sort of high levels of MAC, still macrolide sensitive. However, now there was isolated M. abscessus subspecies abscessus bolletii with kind of a full-length ERM, so a resistant to macrolide strain of Mycobacterium abscessus. And just as a reminder to some in the audience that, the two, abscessus is kind of the abscessus complex is the most common rapidly growing mycobacteria. And we'll get into a little bit of the geographic differences there. And the most common slow growing kind of is the MAC complex, which we'll point out here. So he grew MAC plus a little bit, so sort of a lower titer of M. abscessus.
Hey, John, can I just
Yep.
comment on that real quickly?
Yep.
So a complex is a group of distinct species from taxonomy. So whereas abscessus used to be a complex, now it's a collection of subspecies. So it's really not the best term. It's still written about. I see it every day in articles calling it a complex, but it's probably better just to call it Mycobacterium abscessus and which subspecies it is. That's the more precise way to do it. The other thing is, I'm going to look up this article. It says a saprophyte. A saprophyte is an organism that lives on decayed matter. I mean, I don't know how these get called, saprophytes. Interesting term.
Yeah.
And then, John, there was a clarification question regarding bacterial burden here. Was the 4+ related to the smear status of the patient, or was 4+ a measure of the quantitative culture of MAC for this
The
patient?
quantitative culture. It was smear. I should have clarified that. It was smear positive, I think 1 or 2+, and then on the quantitative culture, it was 4+.
Great, thank you.
So we talked a little bit about this. So, defining exactly what is going on here. Did he truly have a treatment failure? So kind of the top, he was kind of positive the whole time and never cleared never cleared cultures. Is this a relapse? So initially positive, turning to negative, but likely never truly cleared the infection, even if we're not detecting it on culture, and then having the same strain causing the clinical syndrome at a later time, or a true reinfection. So treatment worked, cleared, the culture's truly cleared, and then a different strain or multiple strains causing recurrence. So we kind of brought this distinction up before. And then, even within strains, so every kind of strain will have some degree of, selective pressure over time and have some evolution. There can be mixed strains, so there could be, MAC with 2 different strains that we may not be seeing on culture. So there's kind of 2 strains there, or different species of infection. So there's kind of different flavors here to think about. And just a bit about this. So they're mixed, just about both mixed species and mixed strain infections. So mixed species infections are seen in both CF and non-CF populations. There's been a number of studies looking at this, and there's been a wide kind of range of prevalence estimates, most kind of falling in like the 10 to 15%, some much higher when they're following people for long periods of time and less kind of rigorous definitions of what an infection is. So commonly we'll see different organisms, NTM organisms over time. And then the role of reinfections seems to be in a lot of these studies, when it's looked at, reinfections is half, if not more than half, of the kind of these recurrences from both mixed strain and mixed species, or likely reinfections. And then, as was mentioned before, a reinfection likely most of the time happens later than a true relapse. When we're seeing it kind of under a year, it's more likely to be relapse, same strain. And then we'll just to point out a little bit that the NTM infection really relies on both environment plus host factors to sort of create infection. So we focus a lot on the host factors in our kind of workup. We think about all the underlying lung diseases, genetic disorders, the role of autoimmune diseases and other sort of immunocompromising conditions that are that are both kind of clinically tested and maybe that are not quite to the clinical lab. But there's also the environment plays a large role in what we're exposed to and sort of what eventually becomes a pathogenic organism. There's a lot of different studies. There's geographical differences. So this was a really interesting study of kind of showerhead biofilms and found kind of distinct geography and sort of both MAC and abscessus, so in showerheads. And to point out, kind of in Florida, there's a kind of a red zone down there for abscessus. Whereas in Philadelphia, it's a little higher in MAC, which is kind of consistent with what we usually see. So there's kind of a geographic difference in sort of biofilms and in the ecology. And then sort of some recent work by Jen Honda's group was really interesting, and even kind of between sites. So within Hawaii, she looked at sort of even individual islands, you kind of see distinct makeup of different NTM species. And even within a certain, even within one household, you can kind of find multiple species in sort of one place, one sampling. So it's kind of so it's possible to have kind of an environmental biofilm with more than one NTM species. And then Dr. Thompson did some really early interesting work kind of linking the environment to clinical strains. It's been a bit imperfect, but there's clearly, when we look for it, there's matches between the strains found in a person's environment, or kind of a geographical clustering based on sort of a shared source. It's not always possible, a lot of studies, there's a third to half are kind of matched, but there's definitely is a link between the strains found in the environment and the kind of clinical isolates found. Maybe I'll pause there before we go to the next question. Any comments on sort of the role of the environment and the clinical syndrome that develops? Dr. Thompson.
Rachel, why don't you take that?
Sorry, no. Well, yeah, I mean, they're all very valid points, John. The environment has a big role to play, not only in what we get infected with, but also what contaminates samples in terms of virulence and the breadth of strains and species that are in the environment. It often makes it very difficult to interpret the relative contribution of different organisms when you get these mixed cultures.
Yeah, we do environmental cultures clinically. If someone sends us a sample, and you usually grow something, but it actually has been fairly unusual that we would grow what they have. And whether that's seasonal or they were exposed somewhere different than where they think they were exposed, it's hard to say. I think Jennifer Honda's work is going to add a lot to this, since she is doing so much environmental culturing as well as patient isolate culturing, that maybe we'll start understanding this a bit better.
Yeah, it's a very difficult area because there's so much in the environment, but yet at times it's very hard to isolate because there's all the issues of overgrowth with other non-mycobacterial organisms, and trying to actually find them can be challenging at times as well.
Yeah. So kind of related. So as in this case, does isolation of we'll say the M. abscessus species always require treatment? So you're treating for MAC, or you're thinking of treating for MAC, and then you find M. abscessus. Does this require treatment or not?
While you guys ponder that question, there's a couple questions in the chat related to environmental exposures to NTM. So one question is about whether there's a role for decontamination of the environment to prevent reinfection. And then there was a specific question about how long to run the shower cap of your shower prior to use, or how long to let aerosol settle. Rachel, I once heard a pro-con debate about whether or not people should shower with MAC that you participated in. So I can't recall your thoughts at the time, but I think you said that people should shower. So perhaps you wanted to answer that one.
Look, it depends on the organism. I'll answer those questions in order. The role for decontamination of the environment as part of preventing reinfection is really challenging. There are some simple things that you can do, and I suppose the most useful is to make sure that the hot water systems are turned up to appropriate temperatures. But apart from that, there aren't too many other things that have an evidence base, that have been shown to actually reduce reinfection. And you can go to a lot of pains and spend a lot of money on fancy devices and things, and really without any proven evidence of efficacy. In terms of showers, it depends on the species that you're infected with and what's endemic in your region. The evidence for water is particular for particular species. For example, avium and abscessus have both been found in water and have been linked to water-associated outbreaks, whereas intracellulare seems to be more associated with soil and dust. So if you're in an area where 80% of the infections are due to intracellulare, telling the whole population not to have a shower is not particularly productive. So it gets down to what the patient's got and what their risk from their environment is.
Great, thank you. Maybe in the interest of time, we'll go back to the question. Sorry to derail us during that. Okay. So, hey, Nicole, could you reveal the poll results for this one? So it looks like about half people said no, a small minority said yes, and then there was a third said not sure. What do you guys think, Chuck? Is this how you would have? What are your thoughts on isolation of abscesses during MAC treatment?
I would say that given the amount of information we know at this point, the right answer is you're not sure, right? Yet you need a lot more clinical, radiographic, microbiologic information. What's the bacterial load? How many times have they grown it? Over what period of time? Do they have progressive cavitary disease in the setting of being on treatment for MAC? Then that would make me very nervous that the abscessus was actually real. So I know this is coming, but you'd really need more information to be able to answer that.
Thank you. Okay, let's get this man some more information.
Definitely.
Kira, just one point. The question says always necessitate therapy. For this particular case, we need more information, but I think the real answer is no, it doesn't always necessitate therapy. It may in some patients, but I would say that it doesn't always necessitate therapy.
Oh, thank you. That's a really good point. And we notice now your attention to detail is higher than mine. So
mine too.
Yes, thank you. Yeah, so just to talk about this a little bit, then we'll discuss kind of what happened in this case and what our thinking was. So there's been some studies looking at this, and that granted, a lot of these are case series, they're not controlled, but it does seem that when there's both organisms isolated, it tends to portend a worse clinical course. There's been studies looking at symptom burden over time, radiological progression, culture positivity over time, and it seems that this kind of co-infection seems to have overall a worse clinical course. Yep, there is some nuance to this, and I think this is where Rachel and Chuck were saying that a subset of patients, it's not the majority, but some have spontaneous culture conversion. They'll have one positive abscessus and you'll never see it again, or continued mild symptoms that don't really rise to the suspicion that it's driving disease and is not treated. So while overall this might be a worse marker, clearly there's heterogeneity in abscessus and kind of the clinical correlates to finding it in culture. A couple points about that is, there's a lot of work being done on sort of the kind of clinical phenotype, or the phenotype of abscessus. There tends to be a smooth kind of a smooth kind of phenotype that tends to be early on. And then loss of certain glycolipids kind of changes abscessus from kind of this smooth morphology to a rough, which then it tends to kind of agglomerate together, form these cords, tends to be less intracellular and kind of forms more of these extracellular cords that are more pro-inflammatory, harder to penetrate with antibiotics. So it seems like the behavior of abscessus there's heterogeneity there, depending, at least in part, on some of the strain and kind of morphology. And similarly, there's been some discussion about whether this, it's a true biofilm in the lung, whether abscessus can form biofilms. So this, causing difficulty treating with antibiotics, persistence over time. And then there was a kind of Blue Journal kind of case discussion that I thought was really nice, that kind of had a cavitary lesion that was resected, and then under the microscope kind of found clear evidence of an abscessus biofilm, kind of in vivo. So with all that said, we are thinking on the case. I consulted Dr. Peter Liu, one of my ID colleagues. We thought about it together. And we decided to treat with daily MAC therapy, both for some of the reasons that, the information we had at the time was he had kind of nodular bronchiectatic disease that was fairly localized, not in cavitary. Symptoms were, bothersome cough, but, nothing, no red flags. And then just the discussion of, the toxicity of MAC therapy versus abscessus therapy. We decided to implement therapy directed at MAC, and then sort of assess over time what's going to happen with the abscessus. So our thinking was to treat the MAC and then kind of closely follow. And then I would just say, in close follow-up, he felt pretty dramatically better again as soon as he started MAC therapy. So we started him on the same azithromycin, rifampin, ethambutol, got him to take the full doses, with the phased introduction, and eventually he felt quite a bit better, even fairly quickly. So a bit of his culture data. So this is kind of 2 years ago. He had the 4+ MAC. Then again, he completed the year of therapy, still had MAC, and then when I saw him, he had the this is the smear was 2+, but then grew 4+ again, and then this broth only abscessus with this resistance profile. And then 3 months later, to speak to the question, I tried to get monthly, and then I got a 3-month follow-up culture. He had he had the MAC had cleared, but he now had 2 strains. The labs were running 2 strains of abscessus, sort of still fairly low titer, but persistent Mycobacterium abscessus. So his symptoms had been better, so this might be more of a theoretical question, but say you do decide to treat MAC and abscessus, so sort of a regimen to treat kind of both potential pathogens. There likely is going to be some differences in opinion, but I wanted to sort of get an overall sense of what people would do. Would you do a full treatment of both, so 3 MAC drugs, and then try to find at least 3 or more based on abscessus, IV or oral? So that's kind of question 1. So sort of full treatment of both individually. Would you try to avoid, because his symptoms are relatively modest, do you try to avoid IV therapy and try to construct a regimen that uses PO or inhaled only medications? And kind of a similar next step is, related to that is, do you try to just reduce the overall number of agents you're treating with? Or on the opposite end, do you kind of do a full treatment course and then add on kind of an induction phase plus or minus a surgical consult? So kind of gradations of treatment.
And feel free to write in the chat if one of these options is not appealing to you and you'd like to do something different.
I'm sure there will be more than 3 options or 4 options.
Okay, I'll end the poll now.
So it looks like a lot of people have voted here, treatment of both while minimizing the number of agents. Drs. Daly and Thompson, what would, just rather than the particular poll question, what would be your response? Just how would you manage co-infection of MAC and abscessus in this patient who is clinically improving from MAC, but MAC is eradicated and now has abscessus identified that if you decided to treat?
Rachel?
So say you need more information.
Well, I personally wouldn't treat just yet. I'd like to see more evidence that the abscessus was causing a problem. So I'd probably do a scan at this point and assess his symptoms. If you're going to go, I think if you're going to embark on treatment for abscessus, it involves intravenous agents. And for a patient who's getting better symptomatically, that can be hard to sell. So I would be looking at the scan to see if there is progressive disease, waiting to see that there is persistent isolation of the abscessus and that it's a problem before I went down the pathway of intravenous agents.
Thank you.
I agree. I mean, literally in 30 years in this field, I've seldom treated both simultaneously. I have, but it's very rare. So I usually go after the dominant organism when I can define one by bacterial load, persistent culture positivity over time. Usually we treat MAC first, much easier. And then we survey for the abscessus, add good airway clearance. This person had a lot of plugs in their right middle lobe. I would really want to clean that out. Think about where they might be environmentally being exposed. They had 2 strains of abscessus. Why do they have 2? And then over maybe 6 months, figure it out with imaging, like Rachel said, repeated cultures. And also, how is a patient doing? I can tell you that when we do this, we sit down with the patient and go through all the permutations. We say, here's what we can do. And as soon as you describe one of these regimens you have listed here for treating both, they usually weigh in pretty strongly on not doing that.
And then do you guys have any concerns if treating for MAC are you worried about losing macrolide susceptibility of the abscessus during your MAC treatment while you're focusing on if you considered MAC the dominant and that's what you're going after? Do you make any alterations to your standard regimen in the setting of co-infection with abscessus?
If it's a Mazilliense, that's a theoretical risk, but this patient doesn't have that, so it's already macrolide resistant. If it's a Mazilliense, yes, there can be concern there, and I suppose one thing you could do is to change your rifampicin to clofazimine as your third MAC drug, which gives you an additional agent against Mazilliense. But in that case, I think, you've got to make a decision. Are you really going to treat it properly or not? And then you may want to add Alice as a third drug that covers both. But again, the principles still apply. You want to know that the bug's causing the problem.
Right.
I would just add, so when we are going to do both, that is what we do. We drop rifampin and we put in clofaz. And
yes.
Then we usually add 2 other drugs, usually intravenous drugs, at least up front. So, I mean, I just think if you do it halfway, you get in trouble. So that's the issue. Once you decide to treat both, you need to treat both. And the one place you get a little coverage from clofazimine is very helpful. That's just one drug you don't need, rifampin. Not very good. One of the most commonly stopped drugs. So that's clofazimine is a good choice in that situation, I think.
Great, thanks, guys. Sorry to go rogue with the questions that weren't exactly the questions on the page.
No, that's perfect.
Okay, let's press on. Yeah.
Okay. Yeah. So that was definitely our thinking, and we'll get back to the case in a minute. But we felt that similarly, he had relatively modest symptoms, was feeling better, and doing anything other than MAC therapy was a tough sell. So we did elect to just continue the MAC therapy in this case. There has been a couple case series looking at treatment of co-infection. And this was a particular one, about 80 patients that were followed. And basically the regimens depended, as was kind of alluded to, what was the dominant subspecies? Was it Massiliense or Abscessus or Bolletii? And that kind of guided the choice of agent in this case series. All of them kind of got standard, I think it was close to 100% got kind of macrolide, ethambutol, rifampin. And then the other agents were kind of dictated based on the species. And you can see some of the big differences here. Most of the people with the abscessus infection got more IV therapy. I think there was a higher number of agents and sort of longer duration of therapy. And then just a role about the role of potential role of clofazimine. That at our center, our group kind of looked at a cohort of patients who had both disseminated and pulmonary infection, and clofazimine containing regimens. These are for abscessus infections, not co-infections, I should say. So abscessus infections usually have a fairly low culture conversion rates, high rates of relapse and treatment failure. So in this cohort of patients with lung infection, there was 32 with the M. abscessus pulmonary infection, 9 had lung transplants, 7 with CF, so a fairly sick patient population. Almost 70% had subspecies abscessus. All those were essentially macrolide resistance, and then the other handful, there was about 75% macrolide resistance. Most of them had kind of a nodular bronchiectatic underlying or imaging. And then the use of clofazimine kind of in this series, consisted of an induction phase, which lasted about 2 months, which was generally 3 antibiotics plus clofazimine, and then a continuation with generally a 3-drug regimen of 2 agents plus clofazimine, and usually ended around a year of therapy. So not quite as long as some of the other series. And the outcomes were okay, in that clinical cure in 43%, which meant kind of all 3 sort of at least stable to improving imaging symptoms, and then culture negativity 1 year after follow-up. So a pretty good outcome using clofazimine. And above that, so 60% had, at the end of the regimen, culture conversion, which was sort of higher than some historical case series that tended not to use clofazimine and leaned more heavily on IV therapies. That said, there were adverse reactions. So 80+% had skin pigment changes. 62% had some drug reaction needing to stop at least 1 antibiotic, and then 20% stopped all antibiotics. So there was, significant amount of toxicity kind of in the therapy and follow-up for MAC with kind of clofazimine containing regimens. And then just to kind of spell out, so there are, and this is not an exhaustive list, but kind of a general schema in thinking about potential agents with coverage of both MAC and abscessus. Mentioned amikacin, clofazimine. Bedaquiline has been shown to be fairly effective at treating both MAC and abscessus. Fluoroquinolones, to some extent, there's a role in refractory MAC cases, and at times in abscessus, depending on sensitivity. And then some emerging therapies that are, that potentially have utilization on both MAC and abscessus. And maybe I'll just pause here to say, in your experience when you are treating, or if now with things like clofazimine and bedaquiline, or what kind of regimens would you choose should you had to treat both MAC and abscessus? Do you try to maximize the number of agents that get you dual coverage, or do you choose based on toxicity profiles? Kind of what's your overall theory as to how you construct a regimen?
I'll start. as I said earlier, I treat them both the same way. I treat them separately with overlap between clofazimine and amikacin. But Aquilin, pretty low MICs for MAC, not great for abscesses. Fluoroquinolones don't use for either one. I mean, they're just really not active in vitro against MAC, and definitely not active against abscessus. And even though people do write about it, I mean, in the lab, those just are not active, and we don't use them. Then from the abscessus list there, we tend to use imipenem. We're using more and more omadacycline. Should be a clinical trial starting probably later this year in abscessus with omadacycline. We're using dual beta lactams more and more and seeing some pretty impressive results anecdotally speaking. It needs to be studied better. And there are data from Hopkins and other places showing really good activity in vitro. But my approach is to not use fluoroquinolones and focus on amikacin and clofaz, which we showed with Jakob van Ingen a number of years ago, in vitro synergy between amikacin and clofaz. It's also been shown by other groups. Rachel, what do you do?
Yeah, I agree. We use amikacin, clofazimine, and a macrolide, ethambutol for the MAC, and then imipenem and tigecycline. We haven't got the luxury of being able to access omadacycline or the dual beta lactams at this point. We've tried hard, but we can't get those just yet. But that's a fairly standard combination for us.
Thanks, guys. In the interest of time, I'm going to move us back to the case so we can wrap. We can move things forward and end on time.
Sounds good. And so we'll come back to the case, but just how would you, at this point in the case, so you have a patient with NTM lung disease, now 3 to 6 months into treatment, one pathogen which looked like either relapse or a treatment failure initially, so with NTM or with MAC rather, and then kind of persistent positivity with abscessus. How do you counsel this patient in terms of the likely outcome of his case?
Well, Nicole, let's give people a short period of time to vote. So get your quick clicking fingers.
Okay, I'm gonna end the poll now.
So what do you guys think, our guest discussants, about the likelihood? If you're counseling this, if this patient were sitting in front of you, how would you counsel them in terms of their likelihood of a favorable clinical outcome?
Rachel, go ahead. You take this one.
Yeah, look, I would say yes, there is likely to be a clinical response, and I think that's already been mentioned that the patient is getting better, but there is a risk that the abscessus will increase, and that will cause problems down the track that may require treatment in its own right, and that this is likely to be a long road. It may not require treatment straight away, but it's something that definitely needs to be watched. I would also tell the patient that if we clear the MAC and you remain healthy, there is a chance that you'll clear the abscessus spontaneously. And again, reinforce those nutritional, the nutritional advice, the airway clearance advice, and looking at the environment to see whether there are aspects that can be improved there, use of humidifiers, spas, aerosol exposure, hot water system temperatures, those sort of things that might be responsible for the exposure to abscessus.
I have nothing to add to that explanation.
Great.
Yeah, so as mentioned before, both the outcomes are generally with co-infection are suboptimal, but not terrible, but I would say still suboptimal given our limitations in treatment. In this study, kind of looking at the outcomes of those patients, which I kind of mentioned the treatment regimen before. When the subspecies is abscessus, the culture conversion for both is about 25%. I think this was follow up over a couple of years after. And then for the individual agents, MAC tends to respond. There's a high frequency of culture conversion, but then the abscessus is kind of more resistant over time. when there was culture conversion, it does tend to happen relatively rapidly. So when they did convert, it was generally in the first month or so. But then a lot of them did get better. So even despite kind of not completely clearing cultures, there was a clinical and radiological response in the vast majority. And comparing it to the subspecies Massiliense, the conversion rates were a bit higher, driven mostly by the abscessus, that subspecies Massiliense that converted. And then similarly had, fairly high degree of symptomatic and radiologic response. However, then just to reinforce this point is that, even those with culture conversion, at some point, 88%, half had a recurrence, and the majority of that was a reinfection, kind of based on sequencing. So even with, good culture and symptom response, they're very high risk of getting reinfection. So as it stands today, he had, we just continued the MAC therapy. He continues to have a low level abscessus in this sputum culture. His radiograph is fairly stable to a little improved. We, talked about some of the things, and then, as was mentioned before, some of the environmental hygiene, airway clearance, exercise, and things like that. So we have yet to pull the trigger on abscessus treatment, and he, seems to be fairly happy. We'll see how long it lasts, but that's kind of where the case stands. So take away a couple of takeaway points, and I'll kind of leave time for some general or finishing comments. So that, applying a critical lens, the clinical monitoring. So monitoring treatment is essential. So monitoring both symptoms and microbiology over time, and then, really, and then thinking how to best use radiology, lung function testing, understanding the, complicated relationship between the environment and host, especially given that reinfection drives a lot of clinical failure. And then just thinking about a framework, if you have, a situation where you're not sure, it seems like two bad options, do you treat MAC or treat abscessus? I think we can try to thread the needle between Scylla and Charybdis here and try to take a rational approach to treatment. And I think it just goes without saying that hopefully, we'll get more drug development, better understanding of phenotypes, endotypes, and sort of a more personalized approach to care. Just want to take a minute to thank some of my mentors and sort of our team at Penn, Dr. Hansen-Flash and Dr. Hadjiliadis, Dr. Tino are kind of been instrumental in kind of teaching me and work with a lot of talented people here at Penn. So I wanted to thank them. Their thinking has kind of influenced me and kind of how I take care of patients and think about NTM in general. And then a couple quick announcements are that this is our first in this series. Coming up, we have a TB case from Dr. Christopher Berger from UCSF, and then a fungal lung disease by Dr. Maria Schroer at Indiana University. And then one other PITB plug is that to sign up for the apprenticeship program, you still have a couple days. It's a great program to get involved in the PITB assembly.
Great.
Thank everyone else, and we'll kind of turn it back over for finishing thoughts.
Thank you so much, John. Thank you so much, Chuck, Rachel. You guys were terrific. Thanks for leading this off. I just wanted to add for the March 17th tuberculosis conference, this is to celebrate World TB Day. And one of the guest discussants will be Dr. Neil Schluger from ATS, so who was previously at Columbia, but has now recently moved institutions. And so that should be a great session. You will need to sign up for it to register just like you did for this one. So please be on the lookout, or you can click on the link that Nicole put in the chat right now. And then there are a couple extra questions in the chat that I wanted to ask, but I know our discussants may have to run. Do you have time for 2 more questions? They do. Okay, great. So there's one question about the chat about what's thought to be the major entry mechanism for pulmonary NTM. Is this thought to be aspiration into the environment? Is it gastric aspiration? Is it showers? Do you guys, is there any quantification in terms of the major route of entry of environmental to the lung? Either of you want to take that on?
I don't think you can quantify the relative contributions. It gets down to exploring both in the individual patient. There's certainly some evidence for aspiration, reflux and aspiration. There's certainly evidence from the environment that NTM are in shower heads and that they can be aerosolized, and you can grow mycobacteria in the steam that comes out of a shower. So both are potential portals of infection, and it gets down to exploring both in the individual patient.
Great.
Yeah, I agree. I think they get into our trachea various ways, and it's probably not the same for everyone. And it's why even people who live in a environment, Rachel, you were talking about a dusty place and they have intracellularity, they still are susceptible probably to getting abscesses from their shower. So it's a complex discussion that you have to have sometimes with your patients.
Thank you. And then the last question is about an immunocompromised host. How often should you search for an immune defect in a person? Are there particular characteristics of a case that make you want to look for an interferon gamma pathway mutation, or what would make you go above and beyond just in terms of your immune workup of a patient with NTM disease?
Well, we have a very strong immunology group here at National Jewish who've been looking for years for this, as has Steve Holland at NIAID, and it's very difficult to find very significant immune defects, specifically in the IL-12 and the gamma interferon axis. So I think about it when it's disseminated disease, and there you definitely should look.
Great, thank you. Any last words of wisdom from either of our panelists or our presenter? No.
Well, stay interested. There's a lot more patients out there than there used to be, and there's going to be more, and they're often going to find their way to both pulmonologists and infectious disease providers. So please use the new guidelines to help you manage them. And we look forward to your input into the next treatment guidelines, which will hopefully not be 13 years from now.
Great. So that's a wonderful place to end.
Thank you, everybody.
Thank you.
Thanks, John.
Thank you
Thanks
guys
for
so much.
joining, everyone.